Hi, this is Mandy Horn. I am a women's health nurse practitioner and faculty here at TWU in the Women's Health Nurse Practitioner program. This is just a really quick review of a history for any patient, but collecting their obstetrical and gynecological history, some things that are really important that I just kind of want to review what they are and why they're important. A patient's menstrual history is going to tell you a lot about her overall health and wellness. So the age of her first period or menses is the menarche, and then the cycle length and the number of days of bleeding. So that's your basic information that you need about menses. If the patient is using any type of contraception for any reason, so even not just typical, prevention of pregnancy, we do have patients on various forms of hormonal contraception for other medical conditions. So sometimes you have to be specific about asking that. I've seen nurses or medical assistants not ask that question if the patient is either not sexually active or not sexually active with a male. So there are other reasons that you would use contraception. So it still is a good question to ask. You just have to word it in a different way. But obviously if they're having any issues today, pelvic, vaginal, infection concerns, their pap smear history, which we'll go over in another video if you guys haven't covered that in your class already. Procedures, gynecologic problems, and then just like on every patient, you're doing, screening for physical, emotional abuse or IPV, and depression and anxiety. So when collecting an obstetric history, the GTPAL or GPAL is how you're going to document that critical information. And the terms can get very confusing, so I've listed them out here. The G is for gravity, and that means the total number of pregnancies. It doesn't matter the outcome of the pregnancy, but the total number of times she has been pregnant. If she is pregnant now, you count that in the gravity. The T is term births. So whether that infant was delivered alive or not, she carried a pregnancy to at least 37 weeks and delivered, then that is a term birth. The P is preterm birth, so anywhere between 20 and 36, the end of the 36th week, are all considered preterm. So when you're collecting the history, you do have to ask those questions specifically to ensure. And several reasons for that. If she does have a history of preterm births, we need to know that right away. You should refer her to an OB. If she's had pregnancy losses. So that's the next. The A is abortion. And the term abortion does not necessarily mean a termination of pregnancy. So any pregnancy loss before 20 weeks of gestation, whether that is elective or spontaneous, and that would include an ectopic pregnancy, that is the A portion of that. L is the living number of children, the number of live births. Sometimes you have to specify, perhaps they've lost a child later in life, but the child was born living. You do want to know that information for personal sake, so that you can communicate effectively and in a meaningful way with your patient. So to fill all of those out, you will, an obstetrician, a nurse practitioner, that's all we do. You're just pretty much going to see a G and then lots of numbers. But it does make it easy when you don't do that all the time, just to list out those letters, and the terms can get confusing. So that's why I have them listed out there for you. Taking a sexual history can be very tricky. especially to elicit the information that you really need to take the best care of your patients. We all have implicit bias when it comes to sex, sexual relations, gender identifications, the type of sexual practices, the number of partners that people have. Whether you recognize it or not, there are biases. There are people, I mean, the best thing that you can do as a clinician is to figure out what those are, what your implicit biases are, and find a way to push past them so that you can have a meaningful conversation. This is a link to an excellent guide for taking a sexual history, and it's from the CDC. So we know it's accurate, it's up to date, it's a guideline. That's a link to the page, and then there's an actual PDF of the resource that gives you specifically what questions to ask and how to ask them. There are videos on Bates that show clinicians eliciting a thorough sexual history from a patient. So if you remember the 5 P's, so partners, practices, protection, past history, and pregnancy intention, you're going to cover basically all of your information. But there are specific ways that you can ask those questions that make it very non-judgmental and comfortable for the person sitting across from you. It is always okay to say, I don't know what that means, right? So if a patient is explaining to you her lifestyle, maybe she's in a polyamorous relationship. If you don't know what that means, then you can say, I'm so sorry, I don't know what that means. Can you explain it to me? She's more than happy to tell you about her life and her lifestyle and what that means. Don't let that trigger your bias before you know what that means and how important it is to her. This is a link to STI screening. Chlamydia is the most frequently reported bacterial infectious disease in the U.S. So generally guidelines are if the female is having sex with male partners under the age of 25, then you screen for chlamydia. Typically, chlamydia and gonorrhea screening is done together. It can be done by a urine sample or a cervical swab. The cervical swab is more accurate. But this is a link to the CDC screening and treatment guidelines. So if you do ever have a positive come back, you know exactly how to treat those per the guidelines.